Dr. Gerard Martin is Senior Vice President for the Center for Heart, Lung, and Kidney Disease, the Co-Director at Children's National Heart Institute, Professor of Pediatrics at George Washington University. Dr. Martin is a nationally recognized expert in pediatric cardiology and screening for CCHD. Dr. Martin is a Fellow of the American Academy of Pediatrics, the American College of Cardiology, and the American Heart Association. In addition, he has also served on the American Board of Pediatrics, Sub-Board in Pediatric Cardiology. Dr. Martin is an Associate Editor for Pediatric Cardiology and has more than 100 publications in the field of pediatric cardiology. He is an invited speaker nationally and internationally. And our second presenter is Elizabeth Bradshaw, who is the Clinical Program Coordinator for Cardiac Research at Children's National Medical Center. Elizabeth is responsible for coordinating research efforts surrounding the use of pulse oximetry screening for critical congenital heart disease in the newborn nursery. In addition, she helps hospitals implement pulse ox screening for serious congenital heart disease in their nurseries. Elizabeth has made a number of presentations nationally and internationally and has publications surrounding screening for critical congenital heart disease. And on behalf of the Heartland Collaborative, I'm going to turn the rest of the presentation over to them. Thank you.
Thanks, Jonah. Good afternoon. This is Elizabeth. I'm actually going to be kind of starting out. It's a pleasure to have the opportunity to present this webinar today as the Heartland Collaborative moves forward with implementation of CCHD screening. In April, as Laurie mentioned, I had the opportunity of speaking with the newborn screening program coordinators in the Heartland Collaborative and was able to assess the current status of CCHD screening and also to assess and understand challenges and strengths that were felt to exist in the states and in the hospitals in Heartland. Also, for the states that had not already done so, we conducted a survey of the hospitals to understand the needs that the hospitals at the grassroots level felt that they had. Today, we'll share some of the findings from the calls and the surveys, and we'll also provide educational and background and significance of CCHD screening. We'll describe national and international efforts and lessons learned for implementation, and we'll also discuss several plans for moving forward with addressing some of the challenges that you all feel that you will face. So Laurie provided a very nice overview of the Heartland Collaborative for you already. Through my calls, I was able to learn that in Heartland there are approximately 290,500 births each year in 410 birthing facilities. And in addition to those births, there are around 850 home births each year. No state in the Heartland Collaborative is currently conducting CCHD screening. Sharon Vaz in Oklahoma shared this nice slide. In Oklahoma, there are 60 birthing facilities. 36 are not conducting CCHD screening. 23 are, and there is one nursery or one hospital in the state of Oklahoma who is conducting CCHD screening and following the HHS guidelines. Missouri also conducted a survey this year, and they found that 52% of the hospitals who responded are conducting CCHD screening and 48% are not. Arkansas found that 25% of their hospitals are currently screening, 75% are not. And then from our survey in North Dakota, Iowa, Kansas, and Nebraska, we found that around 30% of hospitals are conducting screening and 70% are not. In each of those surveys, we had around a 50% response rate from the birthing facilities. One hospital in North Dakota has actually been conducting screening for more than 5 years. That's Johnson Hospital. The other hospitals who reported that they are currently screening, or at least most of the other hospitals, started this year. So from the surveys that were conducted in North Dakota, Iowa, Kansas, and Nebraska, we looked further to determine the characteristics of the hospitals that are currently conducting CCHD screening of their infants. There were 33 hospitals in this population. We found that the protocols vary among the HHS protocol and hospital-specific protocols that the hospitals have created for themselves. We found that most folks are screening asymptomatic newborns in their well baby nurseries, 64%. However, some are also including NICU babies in their population. Timing of screening varies. Most folks screen between 25 and 48 hours, but there are some hospitals who are screening from 0 to 12, 6%, and then 13 to 24 hours, 3%. The large majority of screeners are registered nurses, 75%. Some folks are also using nurse extenders. And we did find that around 30% of folks reported that they're conducting screening in conjunction with other newborn screens and daily weight. 33% are reporting outcomes currently, and 51% report that they do not charge for the screen, or 15% include the charge in the admission. 61% report that they include consent with the standard newborn screens, and then 3% report that there is no formal consent. We also looked at the characteristics of all hospitals in the state to determine what resources are currently available surrounding CCHD screening. We found that pulse oximetry equipment is available in most all of the hospitals, 91%. The model and vendor of the pulse oximetry screening, or the pulse oximeters, vary significantly. Nellcor is the most common in 35 hospitals, and Philips, Masimo, Nonin, GE, and Datascope are the others that were reported. Most folks are using disposable sensors, around 75%, and the others are using reusable sensors. Echo and pediatric trained sonographers are available in around 50% of hospitals, and pediatric cardiology services are available in only 14% of hospitals. It was encouraging, however, to see that most hospitals, around 75%, do have an existing relationship with a referral center for the care of their pediatric cardiac patients. And cardiology consultation and telemedicine are available in around 40% of the hospitals. We also asked folks to identify the strengths, and we're very pleased to find that a large number of hospitals and newborn screening coordinators were able to identify many strengths. The main strengths that we found were that most folks felt that they already had the equipment and the ability to perform the actual CCHD screening. So they had the pulse oximeters, they have the pulse oximetry equipment such as the sensors, and the staff know how to conduct pulse oximetry. They also felt that nurses, physicians, and hospital staff are very supportive of the screening. They want to do the right thing. They want to implement evidence-based protocols and provide the best care possible to their infant patients. They felt that the screen was easy to do. Some hospitals reported that they'd like to benchmark their screening results against other screening results in the country. And some folks reported that having pediatric cardiology services on site was a strength for them. We noticed that there are several states who have already created strong collaboratives within the state or work groups within the state to look at implementing CCHD screening in their states. Some hospitals are already screening, and the support from the Heartland Collaborative was noted by several newborn screening program coordinators as a strong resource for them. Also, several folks reported that the infrastructure was already in place in their state to care for children with congenital heart disease. Some of the obstacles that were reported have to do with education. People felt as though they needed resources for educational materials for providers and staff. Some folks were concerned about the cost of screening, so staff time, equipment, etc. Rural hospitals were worried that they had limited access to resources. Some folks reported that they needed standards, protocols. They needed samples of policies and protocols. They wanted recommendations for NICU babies and recommendations for how to manage failed screens. some folks felt that physician and nurse support and buy-in would be a problem, as well as unnecessary transfer of false positives. And most all of the newborn screening program coordinators felt that determining the role of the newborn screening program and determining funding sources was going to be a problem. And lastly, addressing home birth. So for the remainder of the webinar, we are going to provide some background education and as well as ideas for addressing the challenges that you all have identified. And I'm pleased now to turn the presentation over to Dr. Gerard Martin, who will discuss background and significance, overview of the evidence, and national and international efforts.
Well, thank you, Elizabeth. And it is my pleasure to be speaking to this group. It's very exciting to speak with a collaborative. I think that this is really this way in which you are working together is a refreshing and very valuable, and we can all learn from this. So I get to talk to you, and I apologize to those of you who are already screening and know why, but we'll tell you a little bit about our story with screening. First of all is to know just how important this is. There have been many estimates about what is the issue in pediatric cardiology that we should be paying attention to. And as you see from this slide, the issue of unrecognized critical congenital heart disease in neonates is thought to be more important than two other significant issues, that is the sudden death of a young athlete, as well as the, quote, sudden death associated with stimulant medication use. So this is a significant issue, with this estimate being somewhere between 100 and 200 deaths a year in the United States. When we got involved with this, we were looking for a cause to support, and I spoke to Mona Barmash, and Mona is the president of Children's Heart Information Network, and I said, Mona, I'm thinking about getting involved in screening, and I want to know, what should I be concerned about? What's a big issue for parents and organizations that are involved with congenital heart disease? And Mona did not flinch. Mona instantly gave me this quote. She said, Dr. Martin, hardly a day goes by when I do not hear from a distraught parent whose child was not diagnosed at birth. And this led to tragic or serious lifelong consequences. So it was this quote that really got us going and thinking that the CCHD was important. And of course I knew that because in my 20-plus years, almost 25 years of practice here in Washington, there wasn't a year that didn't go by here where we didn't have several babies with delayed detection. How important is it now? Where do we get data? Well, this was a wonderful study that was done by the group at UCLA, Dr. Chang and her co-workers, where they looked over a period of time in California, and they looked at autopsy records of children that had died. And what they found were significant numbers. Here it was in this 5-year period, 152 missed cases of critical congenital heart disease. And what that means, at least in that, if you take that and spread it out, that there's about 30 children a year dying in California alone. So if we look on a national status and we try to blow up the numbers taking births, it's thought that there are about 40,000 infants a year that aren't diagnosed, that there are 40,000 infants a year with congenital heart disease. and about 10% of them, some people might even go as high as 20%, have CCHD. And it's thought that about half of those CCHD patients may die or have missed diagnosis. So it's a pretty significant number when we look across the country. And the median age of death in that study in California was around 2 weeks. So this is some data that was brought to us from the Heartland group, and this was from birth statistics in Arkansas between 2000 and 2008, and it gives us a little bit of a picture of this. And if we look at these bars for the diseases that make up CCHD, which are shown on the left side there, and we look at the 3 ways that you can be, the 2 ways that we would like people to be diagnosed, which is prenatally or at the time at birth. So that would be the purple and the red. That's children that are found. If we look at the blue bars, those are children that are missed. And you can see the number there. It's somewhere right around the 20% number. And we believe that that's probably a pretty accurate number because of other states that are now reporting it. The CDC has been working with the state of Florida, and they have reported a number similarly in Florida in the current era. So that's pretty significant when you think about 1 out of 5 are not going to be diagnosed in a timely fashion. So we now know that this is a kind of a significant issue. What about screening principles? This is an old public health paper that looked at screening, and what came out of this paper was the idea that you screen if the incidence is sufficient, if therapy provided before clinical manifestations results in improved outcome, if the screening identifies the disease before symptoms, and if the test has acceptable sensitivity and specificity. And lastly, if the test is cost effective. So what we've been focusing on here is this incidence factor. The March of Dimes has weighed in on this, and the March of Dimes has said something that we've been saying to families for a long time. They finally recognize that congenital heart disease is the most common birth defect. And as pediatric cardiologists, we haven't been very effective in saying this to the community. It affects about 8 out of every 1,000 live births. So for every 1,000 babies born, 8 will have congenital heart disease. And of those 8, about 4 out of 1,000, or basically half of the group with CHD, about half of them will require treatment in the first year of life. And this data comes from this paper by Dr. Hoffman. Not only do we know that, but we also know that it is a significant issue when it comes to morbidity and mortality. This is data from national statistics, and it's published every decade. And what we see, what we know is that nearly 40% of deaths in the United States in children are as a result of congenital anomalies, and the majority of those congenital anomalies occur in the first year of life. So not only most common, but very, very costly when it comes to morbidity and mortality. Now we're doing great things. And over the last couple decades, we've seen significant declines in infant mortality. Just in the last decade, we've seen a 24% drop in mortality. The decade before that, it was almost a 29% drop in mortality. So we now think that of all children coming to us with congenital heart disease, we're starting to throw numbers around like 98%, 97% of babies that we treat can live with congenital heart disease. And this raises the importance of identifying them. Because if you have effective treatments, you don't want them to die at home or to die in an emergency department. You want them to get to a place where they can be treated. So what have we been doing? And, you know, we've talked about prenatal ultrasounds. Well, prenatal ultrasounds in the United States are detecting about 20 to 25% of the babies. Not particularly good. I remember when I was coming out of training, we had great hope for prenatal ultrasound. In other words, if every obstetrician would just do a screening for a 4-chamber view and a great vessel view, we could find these babies. Well, it turns out that that hasn't been very successful. We're running right around that 20-25% number. In the United Kingdom, where prenatal screening with Lindsay Allen really had its the roots of fetal echocardiography, they too are only seeing about 20 to 25%. Some countries can do a little bit better. Germany's been reporting up in the 50% range, but clearly it is not. The prenatal screening is finding some, but not the majority. So that leaves us with a newborn exam. And what we've been teaching is look for cyanosis, look at the baby. Well, we know that looking at a baby for cyanosis is a little bit unreliable. It's hard to see the cyanosis. We've talked about listening for a heart murmur. Well, we now know that with heart murmurs that there are many false positives. Many of those babies just have normal transitional circulation. We also know of many false negatives. You know, many a child with hypoplastic left heart syndrome that has no murmur whatsoever. And we've talked about palpating the pulses and looking for coarctation. And if the baby's ductus is open, that baby may still have perfectly normal pulses. So from several studies looking at the accuracy, we now know that simply relying on physical exam alone, the detection is only around 50%. Not really good. So why can't we just rely on cyanosis? This is a nice little graph that I thought showed this quite well. And we know that it's hard to see cyanosis, but just how hard is it? We believe that a normal saturation is above 95%. Okay? We believe anything less than 95 is abnormal. Well, when you look at this bar, the median threshold for detection of cyanosis is not until you get down to around 69 or 70%. Many children, depending upon their hemoglobin concentration, from 78 to 95% on their pulse ox or arterial saturation reading have no visible cyanosis. So just think about that. If you can't see the cyanosis until the number is in the 70s or 60s, think about the babies that you're potentially missing because the human eye is not able to detect it. Then figure out that right in your nursery you have a pulse oximeter. In this day and age, it's hard to believe of a nursery or a hospital without a pulse oximeter. In fact, many outpatient offices now have pulse oximeters. We know that it measures the amount of oxygen in the blood, we know that it's non-invasive, and we know that it's painless. So let's go a little bit further with the issue of why it is difficult for us to find these babies and why we have to rely on something like pulse ox. This is the picture from Dr. Rudolph's textbook on fetal circulation. And as all of you know that the organ of oxygenation is the placenta here, and that the oxygenated blood returning from the placenta comes from the placenta back through the ductus venosus, bypassing the liver. Oops. I always joke whenever I say oops while I'm presenting, I always say it's a really bad thing to hear your doctor say, oops. But the oxygenated blood returns from the ductus venosus, comes into the fetal right atrium. I'm hoping you can all see my arrow here. Comes into the right atrium, and that highly oxygenated blood that's returning from the ductus venosus gets predominantly shunted across the foraminal valley, which is a natural fetal opening between the two atria, to the left atrium, to the left ventricle, and out predominantly to the upper body and brain. Blood returning from the upper body and blood returning from the lower body also comes back to the right atrium, but the less oxygenated blood returns to the right ventricle to go out to the lungs, and the majority of that flow crosses the ductus arteriosus to go down to the placenta to pick up oxygen. So we have what is referred to as a parallel circulation here. And that parallel circulation is important because babies that have critical heart disease, here's a diagram of a baby with hypoplastic left heart syndrome. See the very small left ventricle, a very small mitral valve, and a very small aortic valve. These can either be very small, hypoplastic, or they can be actually missing, atretic. And a child with hypoplastic left heart syndrome who barely has any blood going into the ascending aorta can function totally normal prenatally because of the presence of the atrial septum, the foraminal valley, and because of the presence of the ductus arteriosus. So that blood returning from the placental circulation comes to the right atrium, right ventricle, through the ductus, out to the body, supplying both the head and the feet and the abdominal organs. Blood that's returning from the pulmonary veins comes back to the left atrium and courses across the atrial septum to join the blood returning from the two cava. So here's a child with missing chambers, but still has a normal supply of blood to the body because of the presence of these fetal openings. And the opposite of that is true too. Here's a child with a very small right side of the heart. This is a child with pulmonary atresia who has a hypoplastic right heart. And in this circumstance, the foraminal valley shunts the opposite direction. The blood from the right atrium actually has to get to the left atrium because of the small right heart. And then that blood then courses through the left ventricle out to the body. And now the ductus goes the opposite direction. Blood from the aorta actually courses into the ductus to supply the developing lungs. So again, whether you're missing the left ventricle or missing the right ventricle, these fetal pathways preserve your health during prenatal life. Well, what happens in the transitional circulation? Well, sometime between usually about 12 to 18 hours and 5 to 7 days, those fetal pathways close. And when those fetal pathways close, then the child's lifeline is taken away from them. For the child that it occurs at 8 hours of life, they're in the hospital still in a time at which they can be found by the healthcare providers. But if those lifelines, the ductus arteriosus and the foraminal valley, are present at 24 hours of age or 48 hours of age when the baby's being diagnosed, then the baby may not have symptoms, and in some of the babies may not have visible cyanosis, and the child can be discharged. Is it a big problem? Well, this study by Melander and colleagues in Europe showed that it is pretty significant. And they looked at the mean age at which babies were detected with their critical congenital heart disease. And here you see that babies, the time here is across the x-axis, and the proportion here, of course, this is the proportion not yet diagnosed. So we want a low number at the time. We want everyone to be fully diagnosed. But look at here at 2 days of age. And if we look at 2 days of age, the babies with the ductal-dependent systemic blood flow, these are the babies with hypoplastic left heart syndrome. Look at 70% of them aren't found. If we look at the babies with ductal-dependent pulmonary blood flow, these are the babies with pulmonary atresia, 50% of them aren't found at 48 hours of age. Interestingly, the babies with non-ductal-dependent heart disease were found more likely. These are those babies with a small ventricular septal defect, mild pulmonary stenosis, things that really aren't life-threatening, are found because of the presence of a murmur. And as you can see, even out at 7 days, 50% of the babies with the ductal-dependent systemic blood flow are still not yet found. So, and this was not so long ago, 2006. So I remember when the group at Hopkins and then later the group at Long Island Jewish Hospital came out with the very first reports. And to me, it just wasn't intuitive about the whole idea of pulse ox and detecting critical congenital heart disease. So let's kind of go through and see just how it does work. Here's a child with normal circulation. And what we mean by a normal circulation is a circulation that's in series. That is, the blue blood returns to the right atrium, passes to the right ventricle, passes through the pulmonary valve to the pulmonary artery, out to the lungs where there's gas exchange, oxygen added to the blood, carbon dioxide is released from the blood. Blood then returns to the left atrium, fully oxygenated, 98, 99%, goes through the left side here and out to the body. It's a series circulation in that there is no mixing of the blue blood and the pink blood. And of course, in that circumstance, this is a child that would have a 99% saturation. Let's take that child with hypoplastic left heart syndrome. Okay, we still have a normal heart shown over here. Here's the baby with mitral atresia, aortic atresia. Blood is not passing through this left ventricle. The blue blood is still returning to the right atrium. The pink blood is returning to the left atrium. But the pink blood has nowhere to go except through the atrial septum and mixing with the blue blood. So that the right ventricle, which is the only functioning ventricle, has both the fully oxygenated pulmonary venous blood as well as the deoxygenated systemic venous blood. So that the child has a combination of both pink and blue blood, and these children would have a failing saturation because they would not be able to achieve saturation of 100%. The typical saturation that we see is around 90%. How about transposition of the great arteries? The transposition of the great arteries has the aorta here coming from the right ventricle and the pulmonary artery coming from the left ventricle. And in that circumstance, the systemic venous blood comes back to the right ventricle and goes back out to the aorta. And the pulmonary venous blood comes to the left ventricle and goes back to the pulmonary artery. Life in these children after delivery and clamping of the cord is dependent either on an atrial septal defect shown here, where pink blood can come across to increase the oxygen content of the right ventricle, or the presence of a patent ductus arteriosus, where we can get blue blood into the lungs to pick up oxygen, or occasionally some of the pink blood out to the aorta to deliver oxygen. These children are often much more cyanotic, down around the 65% level, and would fail their pulse ox testing. So these are two of our most common cyanotic heart conditions in the first day or two after birth. And that's how pulse oximetry would detect those babies. So we talked a little bit about importance. We talked a little bit about how pulse oximetry would find them when physical exam or prenatal testing wouldn't find them. How accurate is pulse oximetry? And for that, we look at these curves that look at sensitivity, shown here on the y-axis, and specificity on the x-axis. And these are called ROC curves, R-O-C curves. And a ROC curve, what we want is we want a test that has very high sensitivity. We want sensitivity up here between 80% and 100%. And we want specificity that's really high. We want, and this is 1 minus the specificity, which is the false positive rate. So we don't want many false positives. So we want a low number. So we want a test that's up in this quadrant of the curve. And you can see from this meta-analysis, here is where pulse oximetry has been mostly performing, in this upper left quadrant of the ROC curve. It has good sensitivity and very good specificity. Now, the sensitivity and the specificity varies a little bit. It varies a little bit based upon where you measure it and at what time you measure it. This is, in this meta-analysis, they looked at whether you were looking in measurements where only the foot was measured, or were both limbs, both an upper extremity and a lower extremity, and looking for the difference was measured. And you can see from this slide that in early data, the results when you did 2 extremities did seem to have a bit better sensitivity than the studies in which there was only 1 extremity measured. So acceptable sensitivity and very good specificity. In other words, low false positive rates. Now, in 2009, the American Heart Association and the American Academy of Pediatrics started to look at this issue, and because there was getting to be, the question was being called, is it time for all babies to have pulse oximetry before they left the hospital? And the bottom line from that scientific statement in 2009 was that the experts agreed that critical CHD is not detected in some infants. In other words, they said, we're not catching all the babies. Babies are going home. And not only that, is that when those babies go home, some of them die or some of them are injured. So the experts clearly all agreed on that. And they also agreed that based on the literature that was before 2009, they recognized that pulse oximetry may help, that it may help detect those babies that aren't found by prenatal testing or by physical exam. But they failed to recognize that it should be done on a population level. And the reason cited was that there was not a single large population study that was done in non-university setting. In other words, they wanted to know, did this work in a large region, or like a country? And they wanted to know, is this something that could be done in a community hospital without research staff, or did you really have to have that research nurse doing the study? Right around that time in 2009, And we knew this study was coming out. Dr. Granelli in Sweden published her work on pulse oximetry. And what she showed here in Sweden, in a large population-based study, there were nearly 40,000 births, okay, is they showed that they compared physical exam alone with pulse ox with the physical exam plus the pulse ox. And this is important because we're not talking about pulse ox being done alone. We're still going to have a baby go through their normal newborn care. A baby's still going to have vital signs. A mother may still have a prenatal exam, but what we want to add to it is the pulse ox. So we're going to focus in on this column and show that when physical exam plus pulse ox, look at the sensitivity, 83%. Look at the specificity, almost 98%. Okay, so very good sensitivity, very good specificity, and this was very encouraging. The other thing that Dr. Granelli showed was that in addition to that, they found 24 babies in Sweden. They did have some false negatives, so it's important to realize that it's not 100%. And they looked at the false positives. This group right here, they did have false positives. But what she showed was that many of those false positives had other forms of congenital heart disease, or they had lung disease, or they had PPHN, or they had infections. So a baby, the bottom line was, a baby with a saturation of 88%, not visible to the human eye, may not have CCHD, but could have other important problems that you'd want to detect. And so the false positive issue isn't such a big deal because we want to know about those. And this is the slide that shows other critical congenital heart disease, other mild forms, PPHN, transitional lung pathology, okay? The actual normal babies was the minority of the false positives. Very important. Dr. Ewer's group just did this meta-analysis looking at the top 15 studies that were done in large populations. And again, he showed the sensitivity in meta-analysis at around 76.5, the false positive rate very low, average about 0.1%. Okay, so that's 1 in 1,000 babies born will be a false positive. He also started to look at the timing, and what we know is that if you do the test less than 24 hours, you still have good sensitivity, but you have more false positives. That's one of the reasons why we'll get into this, but we believe that you shouldn't probably do the test under 24 hours because you will have more false positives. And he did some work looking at, in the meta-analysis, looking at the 2 extremity versus 1 extremity, and when you add the antenatal screening in. So all this goes to state that there are large population-based studies, and we are ready to add this to our newborn care. All right. What's happening in the United States? How did we get here where the Heartland Collaborative is considering this? The Health Resources and Service Administration Secretary's Advisory Committee on Heritable Disorders in Newborns and Children did an evidence-based review in 2010. There was public comment, and in 2010, that HRSA committee recommended that pulse ox be added to the recommended uniform screening panel. As a result of that work, the HRSA committee asked a number of stakeholders to come together in Washington to plan how this would take place. This is a picture of the investigators that came forth. Here's Dr. Granelli. Here's Dr. Ewer, a leader in the United Kingdom. Okay, let's see. Let me look around. Here's you can't see us today, but here's Elizabeth, and here I am over here. So now you've met Elizabeth and I, and some of the other leaders. Dr. Morrow from Arkansas is right here. And let's see, any other, I know there's one other Arkansas person in here. Where is he? Oh, he missed the picture. He's in the next picture. This group came together and resulted in this manuscript where we came up with a recommended protocol for screening in the United States. As a result of that work, where we really got the American Heart Association, the American College of Cardiology, the American Academy of Pediatrics, and the March of Dimes all on the same page with one protocol, Secretary Sebelius in 2011, September, did come out recommending that this be added to the recommended uniform screening panel. So that's kind of how we got here. She didn't mandate it. It's not law in the United States, but it's a strong recommendation. As a result of that, basically now we're at the point of how the states will adapt that national recommendation. Elizabeth and I worked with, here's the I and here's the Elizabeth, worked with the legislators in the state of Maryland, and we were happy that the state of Maryland was the first state to pass CCHD screening legislation. It stopped short of mandating it. It said, come up with a plan to implement and get back to us in 6 months. That's where the Department of Health was comfortable as a starting point. Subsequently, New Jersey took even a bigger step, and they came out in the summer of 2011 actually mandating it and actually giving them 90 days to implement. And that was a huge step. And it was also kind of a real hardship for the New Jersey Department of Health and for all the birthing centers there, because they really had no warning that they needed to get going. This is a picture right now of the United States and current legislative efforts. It gets updated by the Newborn Coalition and the group 1 in 100, and they are keeping track of legislation as it goes through the U.S. We love the green states. We're very proud of the states that now are introducing. I wish I knew what color that was. I'd pivot up, but pink. So the pink and blue states that are moving along. What we really want to work are on the gray states. So we are moving forward with legislation state by state. The group of stakeholders did come back together this year to try to answer some of the questions, and it was kind of interesting to hear where the Heartland group was coming from and their concerns. Here's my other Arkansas person back here. Dr. Jim Fasoulis at the American College of Cardiology. And again, we had representatives across all the stakeholders, and this is what we came up with. We need to really start creating a coalition, developing a toolkit that all groups can use, identify any of the resources, and really working together. A lot of outstanding issues. Should this be legislated at the state level, or should states just address this as standard of care? Not quite sure. Finance. What are the outstanding issues in finance? Do we have the cost-benefit analysis that says that this should be done? How are we doing with reimbursement and billing on this? Education. Can we create materials so that there isn't this need to reinvent the wheel? Working with the American College of Medical Genetics to create an act sheet. Working with the Genetic Alliance to create teaching materials that can go out. Not only teaching the healthcare providers, but teaching the parents so that they understand what their baby's being screened with. Working out what is the best equipment. Okay, a lot of issues about, can you measure pulse ox in a moving baby? I think Elizabeth will talk a little bit more about that. What is the reporting issues? What are the minimum set of reporting that you want to go forward on it so that you can know about how you're doing as a screening site? And then what research needs to be done? So these are all things that are going on. HRSA has a demonstration project where grantees are starting this work, trying to do some of the research. Industry is working on smarter oximeters so that it helps people follow protocols. There's the health information sector is now looking at this, saying, how can we take the measurement in the pulse ox, immediately get it into the healthcare record, making the screener's job easier, but maybe even going a further step by even getting reporting from the machine to the Department of Health. And really, how do we do this widespread implementation? And what other research needs to be done? So that's kind of the landscape of where we are. And I'm going to catch my breath for a second and turn it over to Elizabeth with some of the real practical kind of hospital-based issues on screening and implementation.
All right, great. Thanks, Dr. Martin. So in 2009, we set out, Dr. Martin and I set out to look at best practice for implementing CCHD screening in community hospitals. Up until that time, most work had been done in academic centers, large academic centers, and very little work had been done in community hospitals. So we partnered with Holy Cross Hospital in Silver Spring, Maryland, to address the concerns related to mainly feasibility of implementing CCHD screening programs. The aims of our work were to identify obstacles to performing CCHD screening. We wish to evaluate our programs designed to screen all eligible infants. And we also wanted to determine the number of infants identified to have CHD through our screening protocol. And lastly, we evaluated the maternal consent process. During the planning and development of the protocol and our program, we met with the hospital leadership and the bedside staff to determine the best practice for incorporating CCHD screening into the care delivery models that currently existed at that hospital. Our ultimate goal really was to implement CCHD screening in collaboration with the existing care delivery models and to limit the disruption of staff. We also conducted education for 100% of all the staff in the areas affected by CCHD screening. We sent letters to physicians, nurse practitioners, and physician assistants. We conducted in-service education for all of the nurses and nursing extenders who were in the areas affected by screening. And in addition, we did hands-on training for the screeners who were actually going to be conducting the screening. We also brought in representatives from the pulse oximetry vendor, Massimo, who really spent time, hands-on, time with the screeners to ensure that they understood how to perform a safe and accurate screen. From January of 2009 until June of 2010, we screened 6,745 newborns. This was 98% of all the infants that were enrolled in our population. 9 babies were identified to have failed the screening test. And of these 9, there were 3 babies who had no additional orders by their primary care physician, and so we assumed no disease in those babies. We had 1 baby who passed the screen with repeat saturation, and we had 1 baby with critical CHD and 3 others with other forms of CHD. Interestingly, we also had 1 baby who had a complete lobar pneumonia, showing that the CCHD screening does detect other pathologies in addition to congenital heart disease. We also found that no additional staff was necessary to implement CCHD screening on the hospital level. We found that the average pulse oximetry saturation of the babies at the time in which we screened was 100%, and the average saturation was 0.2% difference between the upper and lower extremities. The average time required to screen the infants was 3.5 minutes. And barriers to screening were only reported in 1.4% of all the babies that were enrolled. Barriers with relation to equipment, so sensor placement, were the most common in 53% of those 1.4. Barriers with relation to the staff were reported in 22.9%. And I have this one highlighted in red because it's very interesting. When the screeners reported that there was a barrier that had to do with them, with the staff, ultimately 100% of those babies were not screened. So if the barrier had to do with the equipment or the family or the infant, they could ultimately overcome those barriers. But when it had something, when it related to them, such as a busy day or they had too much on their plate, they ultimately did not screen the infant. So through our experiences implementing pulse ox screening as both research and a standard of care, we set out to help other hospitals implement CCHD screening with the vision that all infants with critical CHD will be detected before leaving the newborn nursery. We set up created a educational toolkit that is available for hospitals to help them with implementation. The toolkit contains implementation recommendations. It contains the recommended screening protocol, educational materials for both providers and families, competencies for providers, and advocacy resources and patient stories. One thing that I'd like to note quickly is that we feel that perhaps the most important piece of education that you should relay to your parents is that this is a screening test. It does not detect all forms of CHD or critical CHD, and parents really need to be made aware of that. We don't want parents to go home with a false assurance. We distributed our toolkit to almost every state in the United States, with the exception of Montana. We have also distributed the toolkit and have worked internationally. And you can see here where the toolkit has gone in the Middle East. It's also gone to the Philippines, India, Australia, British Columbia, Great Britain, Mexico, and Nigeria now. And most recently, we've had the opportunity to work with the Health Authority of Abu Dhabi to implement screening in their 23 birthing facilities. In January of 2011, we hosted train-the-trainer workshops in Abu Dhabi, in which physician and nursing representatives attended a one-day workshop that was followed by a site visit. We provided one-on-one instruction at the site visits, but the purpose of the train-the-trainer workshops was to have providers come to the workshops and then take the materials back to their hospitals. 2 hospitals in Abu Dhabi, the Corniche Hospital and Tawam Hospital, were the first organizations to begin screening their infants. And their experiences were very valuable in that they were able to share their experience with implementation with their neighbor hospitals. In the first year of screening, we were able to screen around 89% of all the births in Abu Dhabi. This was 17,500 infants, and 10 babies with critical CHD were identified due to the CCHD screening. So through our experience with both research and implementation, we've learned a lot about lessons learned for best practice with regards to implementation, and we'd like to share a few of those best practices with you. First, with relation to planning, I cannot emphasize enough the value of both bedside and leadership involvement in the creation of your protocols and standards. At one hospital, we failed to do this. We met with only leadership and took our recommendation for how to implement CCHD screening in their hospital back to the staff, and the staff just looked at us like we were crazy and said, "There's no way that's going to work in this nursery." So really involve your bedside staff early. They have a great understanding of what actually occurs at the grassroots bedside level. So involve them early and make sure that they provide feedback on the plan that you create. Also, as I mentioned earlier, no additional staff has been necessary on the hospital level for implementing CCHD screening. Also, there's no one-size-fits-all for implementing CCHD screening protocols. Each state and each nursery should determine how best to implement screening in that population and just determine what works best for you. A champion for screening is a must. We typically identify both nursing and physician champions. These individuals turn out to be, or can be the content experts and the cheerleaders for CCHD screening. They're a go-to person. And this is especially important in the early stages of implementation when the providers have questions about CCHD screening. The newborn screening program coordinators in each state already appear to be the natural champions for programs in Heartland. Education is perhaps the most important factor to leading to a successful program. Frontline staff will need to be educated on the screening protocols and correct methods for performing screening. Screening protocols can oftentimes be confusing for staff, and also nurses and physicians and other providers involved in screening should all be educated. In a few minutes, we'll talk more about educational materials and resources that are available. Badge cards and posters can be helpful in reminding screeners of the protocols, and the train-the-trainer model has been a very valuable method of educating that we've found to be effective in that you can really disseminate the knowledge and the education quickly with this model. We've also found that compliance increases quickly with the first true positive. This little guy here is Amani, and he was the first true positive that we found at Holy Cross Hospital. Up until the time, so we implemented screening in January of 2009, and Amani was identified in March of 2009. And up until the time that he was identified, we had, every week there were around 30 babies who were missed. But Amani came along. He was a 9-pound, 15-ounce beautiful baby boy who was pink and thriving. He had stats of 91 and 93. And the nurses actually, conducting his screening thought that something was wrong. He was probably fine. And then he turned out to have critical CHD. After that, all 100% of babies were screened in the nursery at Holy Cross. Alrighty, so as you prepare to start your screening program, I'd like to walk you through an overview of kind of the nuts and bolts of how to conduct CCHD screening in your nursery. This is a list of supplies that you'll need. Pulse oximeters, at least one pulse oximeter to be used for screening and one for backup. Depending on the size of your nursery, you obviously may need more than one pulse oximeter. Infant disposable or reusable pulse ox sensors. If you're using disposable sensors, one sensor for each infant. And then if you're using the reusable sensors, which we see most folks doing now, one reusable sensor with a backup, and then also the wraps that are needed to secure the sensor to the infant. Those wraps are around 78, 80 cents per baby, and the reusable sensor is around $150 or so. So all said and done, it turns out that screening with the reusable sensors is around $1 per patient, which is more affordable than the around $12, $13 with the disposable sensors. So we found that it's helpful to pair CCHD screening with another screening test that's already standard of care in your nursery and that's also scheduled to be performed after 24 hours of age. This helps to improve compliance and also helps to ensure that all infants are screened. We most commonly see that CCHD screening is paired with metabolic or hearing screening, and this is the Heartland states. In your survey you reported the exact same thing. It's best to do the pulse ox screening when the infant is quiet and most preferably when awake, actually. If an infant is in a deep sleep, he or she may have DSATs that could lead to false positives. Also, we encourage screening to be done when the parent is present so that they may help to soothe and relax the infant. And this is also, for nursing, this is a very valuable teaching time. The best places to perform the pulse ox are around the outer aspect of the palm and the foot of the infant. On adults, we use the finger, but for an infant, this is not a good location due to their small size. With the CCHD screening, it's recommended to screen a right hand and one foot. The red light, or the light emitter, typically goes on the top of the hand or foot. And if you're using a disposable probe, there's sometimes a star or another symbol on the probe to indicate which side of the probe goes on the top of the hand or the foot. If you're using a reusable probe, there may be a red bar or another symbol to indicate which side goes up. We like to use little reminders like star to the sky or raise the red bar to help providers remember. The side of the probe that's the photo detector should be placed directly opposite of the red light emitter on the fleshy portion of the hand or the foot. To accurately obtain the oxygen saturation, the two sides of the sensor, the two sides of the probe, need to be directly opposite of one another. So with conventional pulse oximeters,
welcome to GoToWebinar, web events made easy.
Wave, when the pulse wave is stable and the heart rate is what you would expect for an infant, the screener may report the oxygen saturation. A limitation to some of the conventional pulse oximeters is motion. So if you're using this type of oximeter, it's important to make sure that the infant is calm and quiet and still. If you're using one of the new generation pulse oximeters, there are two confidence indicators that you can rely on.
Welcome to GoToWebinar, web events made easy.
And the signal IQ to ensure that they're strong. The perfusion index is an assessment of the strength of the arterial pulse, and then therefore an assessment of the perfusion to the site that's being monitored. The PI can range for an infant anywhere from 0.202 to 20, and most newborns should have a PI of greater than 1. However, there has been recent research to show that a low perfusion index may be indicative of CHD. So that's just another consideration. The signal IQ assesses the system's confidence level in the strength of the pulse rate and the oximetry measurement. When the signal IQ is not strong, a little message may appear on your screen that says low signal IQ, in which case you need to replace your sensor. So once you have your accurate oximetry reading, you can document your readings and proceed per nursery protocol. This is a diagram of the protocol that's being recommended on by the HHS. We conduct pulse oximetry on the right hand and 1 foot following 24 hours of age. If the pulse ox is greater than or equal to 95% for the right hand or the foot, and there's a difference of equal to or less than 3% between the right hand and the foot, then the infant is passes screening and has normal newborn care. If the infant has a pulse ox of less than 95% for both the right hand and the foot, or if there's a difference of greater than 3% between the right hand and the foot, then the infant is referred for additional testing. If the infant has, and this is actually not indicated or shown on the screen, but if the infant has a pulse ox of less than 90% in either or both extremities, that baby is an automatic fail and doesn't need additional screens. However, if they land in this range, basically with the stat of less than 95% for both, well, between 90 and 94%, or a difference of greater than 4, then we repeat the measurements for a total of 3, or 2 additional times, 3 total. And if the infant continues to have failing saturation, then they're referred to their pediatrician for clinical assessment. So we're going to take a few minutes and just go through several examples of oxygen saturations that you could encounter in your nursery in an infant. And I think what we're going to
Welcome to GoToWebinar, Web Events Made Easy.
and raise their hand, and then I think either Shona or Laurie will call on you, and you'll be able to answer the question and tell us if we have a failed or a passed screen. So in example 1, we have an infant with an upper extremity saturation of 100% and a lower extremity saturation of 96%. So using the screening protocol, determine what you think this would be, and then raise your hand.
I have Kim Piper with her hand raised.
Okay, Kim, go ahead.
You should be unmuted.
Kim, let us know what you think.
I unmuted her. Let's try Carmen DeMare.
Carmen?
Kim says pass. She responded by text.
Okay. That one is actually a fail. The reason why is because there is a greater than 3% difference between the two. It's a 4% difference, so that one would be a fail. So what we're going to do is move on. It's a 4% difference. So the baby we'd wait an hour, and they would be screened again. On the second screen, we have an upper extremity stat of 99 and a lower of 98. So can someone in the audience raise their hands and tell us what the baby would be?
Kim.
It's a pass.
Perfect. Yes, it's a pass. All right. So that baby would go on to normal newborn care unless he or she had other signs or symptoms of congenital heart disease. So in example 2, we have an upper extremity saturation of 96 and a lower of 94. Is there anyone who would like to answer? Shona? Okay, we'll keep going. This one is a pass. We have one saturation that's equal to or greater than 95 with 96, and the difference is less than, it's 3% or less between the two. So this baby would be an automatic pass. With example 3, we have an upper extremity stat of 89 and a lower of 87. So this baby would be an automatic fail since we have one or more extremities or saturations less than 90%. That baby is an automatic fail. And that one actually does not need to have additional testing because both stats are less than 90. All right, so in example 4, we have one stat that's 92% and another one that's 96. This baby would be a fail because we have a 4% difference between the two. So with this baby, we'd wait an hour and then rescreen. In the second screen, we have an upper extremity stat of 92 and a lower of 94, which would also be a fail because we have both extremities less than 95%. And then on our third screen, we have a 92 and a 92, also both less than 95%. So that baby would fail, and we'd have no additional screens. We'd refer to the pediatrician taking care of the baby, and he or she would be referred for clinical assessment. All righty. So moving forward, we're going to discuss a few of the challenges that both the newborn screening program coordinators and the hospitals identified through our calls and surveys. And this is just an overview. We presented these already, but this is an overview of the challenges that were presented. So one challenge is education. Folks noted that they needed education resources for both parents and for providers. There are several resources that already exist, and so there's really no need to reinvent the wheel. Baby's First Test is a group that's sponsored by the Genetics Alliance, and they have a wonderful website, babiesfirsttest.org, that has all kinds of resources for both parents and for providers. They have also sponsored the creation of the HeartSmart videos that we at Children's National are working to create. The HeartSmart videos are going to be available in June of 2012, this June. We have one video that's for providers. It's around 13 minutes long, and then we have a video for parents that's around 6 minutes long. So these videos are going to be available free of charge, and we're really excited to be working with Baby's First Test to release these. The CDC also has resources available. I've told you a bit about our resources. And then some of the parent advocacy groups have great resources, 1 in 100, Teach-In, Mended Little Hearts. These folks have a nice compilation of resources as well. And the vendors are now starting to put together very nice resources. So a lot of resources exist. You don't necessarily need to create your own. Just use what's already been done. Other best practices that we've heard about in the Heartland states are for dissemination of education and knowledge are the Arkansas Angels program. Another program called Learning on Demand is a program that Arkansas is creating, and they have potential plans to develop web-based training and video conferences for nurses and hospitals that include CEUs. Kansas Train is another resource. Some folks mentioned that they would like to pair CCHD screening with the site visits for other newborn screens and conduct educational efforts that way. In Iowa, they have a statewide perinatal care program, which I think is just great. They have a perinatologist, a neonatologist, an OB nurse, neonatal nurses, nurses who are certified in specialties, and a neonatal dietitian who go out to do site visits to every hospital in the state on a regular basis. And one of their potential plans is to include CCHD screening in the work that the perinatal care program does. Also, Missouri has a annual hospital association conference, and they plan to potentially add CCHD screening in this annual conference. So the newborn screening program coordinators, I think, all cited funding and determining the role that they would play as the two main barriers to their implementation in the state. This is a common concern in other states, and to date, I would say that the funding available and the manner in which the legislation and the mandates are written have determined the role of public health. As Dr. Martin mentioned, New Jersey was the first state to address these concerns, as they implemented CCHD screening statewide with an unfunded mandate. New Jersey assembled a work group of eager stakeholders and experts to create recommendations for screening protocols, and they also this group of stakeholders also pushed out the their educational efforts and helped to create plans for tracking of outcomes. Several of you in the Heartland states are doing similar work. As Dr. Martin also mentioned, recommendations on the minimum data set are currently being established, and the HRSA CCHD screening demonstration programs will be very valuable in educating us on the role that public health should play moving forward. We believe that thoughtful and thorough surveillance will be beneficial in assessing the outcomes and also the impact that CCHD screening will have on a public health perspective. Another challenge that was raised is addressing the home deliveries. In the Heartland states, there are around 850 home deliveries each year. You all reported that waivers are common in the population that chooses to deliver at home. However, in order to create plans to address these home deliveries, it's a good idea to include midwives in your CCHD collaboratives, and also learn from the metabolic and hearing screening programs that currently exist. We heard that some states choose to use local health units for the screening of their newborns. Some of the midwives perform screening in the home, and others use the pediatrician's offices as an outlet for screening.
So, I don't know, I think it's quite unfair right now because after Elizabeth got to do all those fun things, she turns over costs to me. So, I guess that's all right. This is an old paper by Koppel in which he compared the pulse ox screening for what this time he called it CCVM, which is our CCHD, to this metabolic screening for either hypothyroidism or PKU, to the actual cost of congenital hearing loss. And he had an estimate of frequency, he had an estimate of the positive predictive value, and basically he came up with the idea that the cost was negligible. Elizabeth has talked about the cost per baby, that the cost per baby has been somewhere between $1 and $13, depending on whether one uses reusable or single-use probes. We've also seen a time study in New Jersey in which they looked at the amount of time spent in nursing care. And again, they came up, even though they were using reusable probes, that taking into account nursing time, that dollar amount, somewhere around $10 to $15 was in order. So clearly, if we were to compare this with doing an echocardiogram on every baby, we would, which is really quite costly. We see that the estimates are that pulse ox screening is cost effective. This just was published again by the Dr. Ewer's group in the United Kingdom, in which they modeled the additional cases found in their research and the cost. And what they talked about was that, for every 100,000 live births, one would find almost an additional 30 additional cases of CCHD. And the cost per timely diagnosis was about 24,000 pounds, which is around 35,000 US dollars. So remembering that some of those kids would die and that some of those kids would require perhaps longer ICU stays because when they got admitted they had more heart failure or renal failure or neurologic issues going on. That additional 24,000 pounds meets the willingness to pay threshold, which is typically set around 100,000 pounds in the UK. So it was felt to be, in this modeling, cost effective. Now, we started to kind of think about some of the barriers and some of the comments that are made by university-based providers. And people in universities often might make a comment like this, that rural hospitals lack resources to pull this off. Well, what we do, that's a bias, and people do believe that. But what do we know? We know that rural hospitals have the same disadvantages as urban hospitals to detect low oxygen. In other words, here in Washington, D.C., a nurse has as much difficulty seeing cyanosis as a nurse in a rural area. And we know that the screening is only going to identify babies with low oxygen and allow them to make a plan. And so what do? A baby with low oxygen. What are our options? We can send that baby home undetected, or we can get that baby to a referral center for a full evaluation, or if we plan ahead, maybe if we don't have all the resources available at our center, maybe utilize telemedicine and bring those resources to the rural setting. So this is where I believe that as healthcare providers, we're being challenged to think out of the box, and I think it's quite valuable. False positives mean unnecessary transfers. Well, the false positive rate is low, and people keep talking about this, but what do we know? Well, probably 1 in 1,000 have a false positive. And really, if a baby is blue from lung disease or if a baby is blue from heart disease, that baby needs to be transferred if you don't have the means to care for it regardless. So the big thing is you got to have a plan. And that's what I think the Heartland group is doing now. They're getting a plan. So in most of the hospitals, as we saw in the needs assessment, most of you do have plans. And you also have centers for health learning, distance health learning. There's an infrastructure in place for telemedicine. And you have cardiologists in your area that are willing to train sonographers to do pediatric echoes if they only do adults. So I think you're well positioned. I do think you need a standard protocol. The protocol does exist that went through the kind of national vetting. You may decide in the Heartland that you want to modify it a little bit. Certainly New Jersey did. I think you need to think about your babies in the NICU. It is now, we're seeing more and more evidence that maybe as high as 10% of the babies that are missed are coming out of NICUs. And so have a plan for the NICU babies. And that data on the NICU babies comes from our work where we're actually looking at a population of one insurer. And most of their babies with failed detection came out of NICU. So follow protocol, figure out when you're going to screen. And as we did with Amani, focus on the positive outcomes. I'd like to thank Children's National Medical Center for freeing up Elizabeth and my time. Certainly also we get funding from the Deckelbaum Family Foundation, and we'd like to thank Heartland Genetics and the Newborn Screening Collaborative and Shona and Lori for all the organization they put into getting us this far. So we'll stop there, and we are available for any questions.
Thank you, Dr. Martin and Elizabeth. This is Shona again. We did have two questions come up during your presentation. The first one was directed to Elizabeth, but I think either one of you could answer. I'm not 100% sure on that. The question was from Lorenzo Botto, and his question on the study that you did with the babies in your population. He asked, of the 3 to 4 babies said to have non-CCHD CHDs, some did not seem to have a heart defect. PFO is not a heart defect, is that correct? Would that change the FPR that was calculated?
So we did, I think the first thing that I need to point out and that we need to remember is that the screening protocol that we used for our research was did not include the repeat measurement. Well, it didn't include the repeat measurement. So we did have several false positives, and the PFO is a normal finding in newborns that should not be counted as a true finding. But yes, we did have several false positives because we feel because the protocol that we were using was not the most up to date and didn't include the repeat measurement.
But that still keeps us in that ballpark of about the 1 in 1,000 for false positives, so that's important. And remember, ours was a implementation study, not an accuracy study. So, and we seem to be having fewer and fewer false positives as time goes by.
Okay, the next question is from Susan Nigro. If you get 1 fail and 1 pass, which one is correct?
So that one, if you fail and then you retest and you pass, you pass. Remember, the protocol states that if your first test has a SAT less than 90, which would be an 89 or an 88 or an 87, then you're an automatic fail and you don't retest. But if you're 90 to 95 or have that more than 3% difference, which is a 4% difference, then you would retest. And if you pass at any time, you're a pass, unless, for some other reason you have symptoms or physical findings that suggest that you need to be evaluated by a healthcare professional. So you don't retest someone that passes,
right,
unless there's clinical suspicion of disease.
Right. Okay, the next question is from Kim Piper. Can you check the hand and foot at the same time using a bedside and portable machine? So we recommend that you use the same machine for both your screenings because the oximeters could be calibrated in a way that probably is not likely, but it could create differences in the oxygen saturations that you obtain. So we recommend that you do one after the other. You don't want to wait too long between screening. You don't want to. You do want to do them simultaneously, but they don't have to be in parallel.
We are aware of some hospitals that have bought 2 pulse oximeters and do them simultaneous, but it's the same machine.
Right.
It's the same brand, but as Elizabeth said, we do not recommend that. We're hoping that the pulse oximetry manufacturers will start creating machines that are screening friendly. In other words, that they will have protocols built into them and that will allow simultaneous measurement with the same calibration of upper and lower.
The next question is a little off the subject of CCHD screening from Jackie Lease. She wants to know what is the value of BPs prior to discharge of infants from the newborn nursery. Do you recommend routine four quad blood pressures prior to discharge on all newborns? If no, why not?
So the easiest answer to that is no, and the why not is that there is no data to support doing it. The issue with blood pressure measurements, I mean, we do have normative data. If you think the pulse ox is difficult, wrapping something around the extremity, wrap the blood pressure cuff around and blow it up on the baby and then have the baby moving. You know, we do interpret them. We get them when we suspect heart disease, but as a screening test, particularly where with coarctation, the duct could be still present and there could be right to left shunting at the ductus, the pulse ox is more accurate. One of the hospitals we worked with in Kuwait did this for a number of years, where they did both upper and lower extremity blood pressure measurement and the pulse ox, and they really never found anything that way. So I think it's timely. It costs a lot. It takes a lot of time, and there is no recommendation to do it.
Okay, we have a couple more questions. The next one is from Brenda Moffitt, and she asks that you please address the time of the screen at 24 hours of age and the race against closing ductus in an infant with significant CCHD.
So it's interesting. The UR does screen prior to 24 hours. They screen closer to 12 hours, and the way things are set up there, they accept the greater false positive rate. It has been our feeling in the United States, given the geography and that we are just so much more spread out, that there is going to be less tolerance for false positives. And therefore, there has been a movement towards screening at 24 hours. Now, if that's at 23 hours, you know, because, you know, of the discharge policy at your hospital, we think that's fine. But it should be as close to 24 hours as possible, just simply to decrease the false positives.
Lorenzo Botto had a follow-up question. He said, can you share your experience with NICU protocols? Are those available?
There are no published NICU protocols. What we've seen is a move towards just a general recognition that when the child's conditions of prematurity or conditions that has them in the NICU are over with, in other words, you're on room air and you're feeding and growing and you're ready to move on, that you know, at the time of discharge is the time that you would get that screening done.
But the NICUs who have implemented have used the same protocol that the HHS recommends, just with a revised time of screening.
We have just a couple minutes left before 2 o'clock Central Time. We want to use everyone's time wisely. So I have one more question. If there are any other brief questions, please send them now. Kim Piper had a follow-up question. Are there studies regarding the S&S of bedside units versus portable units?
Not that I'm aware of. bedside oximeters versus portable oximeters, handheld? No, not that I'm aware of. But we've been told by the vendors that there is no difference in accuracy between the bedside and the portable. And we haven't noticed any higher false positive rates with the folks who are using the portable oximeters.
Now, I guess one of the things that I would state is that for anyone that would like to contact or thinks of a question later, we are happy to have you either visit our website or contact Elizabeth directly. And I believe, there was one more slide. Elizabeth, it's good to be working with a nurse because she's always thinking. There's our website, childrensnational.org/pulseox, or you could contact either Elizabeth or me.
Wonderful. We don't have any more questions online, except that there have been several questions about sharing the slides and the availability of the webinar, and I will be following up with everyone who registered and participated to let them know when and where this will be available. And I think Lori had some closing comments.
Well, I just wanted to thank, again, Dr. Martin and Elizabeth. This was just very informative to get into the nitty-gritty of this work, and so I just really appreciate your time and expertise. I also want to thank all of our attendees. This is our first webinar for the Heartland region, and so we hope that this was successful and met your needs. And again, I just wanted to say thank you, and also I had a comment for Dr. Martin. The fact that you put up, in a sense, refuted the explanations I've been hearing of challenges about screening in our region. That was extremely helpful. That was, for me, that was probably the most helpful slide, to just see it in a different way or through a new lens. And so I really appreciated that insight. And to Elizabeth for doing the survey in the states that have not yet surveyed their hospitals. I appreciate that extra effort. I think we learned a lot that way. So anyway, Shona, you have anything else?
I think we're finished. So other than saying thank you and enjoy the rest of your day, I think we're done.
Thank you.
Thank you both. Thank you, everyone.
Bye-bye.